Screen. Okay, great. So you had a very good talk, just on Tuesday, and it was extremely well attended. We had almost 500 people attending that talk, which speaks for the popularity of Siddharth Dattagupta as well as the topic. And for I think there is no more important no more important topic than to learn the language that pathologists speak. And Dr. Gupta went very, I thought, very, very well. Going right from A to Z, covering so many different terminologies along the way. He talked a lot about terminology which was appropriate for both growths and for microscopic descriptions of various things that you come across in pathology. Today, I'm not going to talk about terminology in general. What I'm going to talk about is patterns in pathology. And patterns in pathology are very much part of the language that we pathologists speak. Okay, so let's just start with this. Okay, and you might ask, why do I have to actually know the sequence? I think, again, we've got somebody who's Shweta. Who is Shweta? Giri, please, I don't want to receive a annotation request. Okay, all right. So we have, this, we need an essential thing for diagnosing whatever we do in pathology, and for this there is a sequence, and all of you do know what that sequence is. Okay, and that sequence is, you need to make good observations, and those observations are both positive and negative. Along the way we will see what these observations can be. Then you have to interpret the observations, and sometimes the observations and the interpretations go hand in hand, or maybe the same thing. When you look at a cell, say for instance, that has got some inclusion in the cytoplasm, that's the observation. Okay, the interpretation is that it is a mucin secreting cell. But sometimes when we are making these diagnoses or descriptions, we just say mucin secreting cell. It includes the observation as well as the interpretation. But nonetheless, you should try and make an observation first and then the interpretation. If you need to do anything ancillary, you have to ask for the appropriate investigations, put all that together, analyze it. But it's not a simple analysis. You have to put it into a context. You can't make any kind of analysis without knowing the context. And the context is the framework in which we do our diagnosis or anything else that we do in pathology, whether it is histopathology or it is hematology or it is clinical biochemistry. You cannot release a report or a diagnosis without first knowing the clinical context. Okay, so we need context. We need sometimes to think of other possibilities, and that's what we call a differential diagnosis. Then we narrow down those possibilities. Sometimes we have to do additional investigations, but ultimately we come to a final diagnosis. And all these different steps require a facility. That means you need to be familiar with the language that we as pathologists speak. Okay, today I think that I'm only going to talk about how to do this, how to improve your diagnostic skills by observation and interpretation. All right, when you have observations and interpretations, these two together make a description. Now, one second, this thing is, to make a description in particular, you need to be familiar with normal histology and its variations. This is extremely essential. I don't think that any of us should be trying to make descriptions without understanding what normal histology is, and normal histology is always not just one pattern. There are many different variations, and we should be familiar with that. And I would advise all of you, any one of you who is listening to this talk, or who are going to practice pathology, you must keep a copy of some kind of histological book or textbook in histology. Or of course nowadays we have our Google and you can look it up, but you must do that and you must be familiar. Now you cannot keep on looking up these these things in Google. So if you're looking at something for the first time, then please compare it with what you're expected to do in a textbook, etc. Otherwise, you will see things that you think are abnormal but are actually just a variation of normality. This is what we are now trying to do. To make a description, you must use professional terms. That is the language that pathologists speak and understand. Because if you don't use the terms appropriately, other people will not understand you. And if you have a wrong concept of what those terms mean, then you may not be able to understand what other people say, or for that matter, what the textbook is describing. Okay. Now, what is a good description? And I say this time and time and time again. All right, a good description. I've got another annotation request. Just be very careful that you don't put your cursor or your finger or whatever else on that little squiggle that is near the top of your screen, because then I get requests for annotation and it is disturbing both to me and to whoever is watching. All right, so a good description, and this is what I mean sincerely, a good description is one that will allow an experienced individual, say somebody like myself, to render a diagnosis without having examined the slide, because the person who is describing it is such a vivid description that you feel that you are actually looking at the slide and you render this diagnosis, and the diagnosis is going to be right because that description has been so true to whatever that particular slide is showing. And literally, I say that a good description will make a blind woman or a man see. Yeah, it has to be that quality of description. Now, to make those good descriptions, you need to use an appropriate language. Because if you mean you're seeing something, but you describe it inappropriately, you use the wrong term, then it's not going to really help in the ultimate diagnosis that you're going to make. Okay. Now, if you want to put this all that I have said into one sentence, you need to develop a system of examination which you use in a given context after appropriate analysis. This is going to lead you to an appropriate diagnosis. And in that system of examination comes this good description for which you need a language. Now I'll just give you one possible system. Okay, this is a scheme. You have made a description. Now you have to analyze it and you have to put it into a context. And this is something that I'm sure the clinicians, you're getting an echo. Is somebody's mic? Whose mic is on? Can you switch off your mics, please? All of you, so then we know from where this is coming. Can you hear me? Any one of you, maybe Shrutika?
Yes, ma'am, we can hear you.
So it's not my
no, ma'am.
Yeah, it's not my mic.
The echo is gone. The echo is gone.
The echo is gone. So it's somebody's mic and we don't know who it is. Okay. So you start, and I'm sure that you did learn this when you were doing clinical medicine, but it is true of pathology as well. So when I see, or I made a description in my head, it echoes back again. So whose mic is on? Not sure. It is it congenital or acquired? Is it physiological or pathological? The next question is, if it is pathological, it's the next question in the algorithm. Is it neoplastic or non-neoplastic? If it's neoplastic, is it benign or malignant? If it is malignant, is it primary or secondary? So what I am trying to get you to understand is that this is the way you analyze something that you have already seen, made observations, made interpretations, and made a good description in your head. You analyze all of that in a given context. And then you ask, if it is non-neoplastic, you have to go through all of the different general pathology the chapters in your textbook, whether it's cell injury, do I think that this is acute and chronic inflammation, etc., etc. Okay? I don't know why we're getting this echo today. Anyway, let's start with this. What is a pattern? All right. Let me just tell you what it is so that you don't get confused with what cellular details are and what is a pattern. Pattern is not about describing a cell. You had a lot of that in Dr. Dasgupta's talk because you describe cells like balloon cells, mucus secreting cells. That is not a pattern. Okay. A pattern is an arrangement. Now this is a description. This is a definition from the Cambridge, oh God, I spelled that wrong, English dictionary. But this is what it is. It's an arrangement, especially a design made from repeated lines or shapes. If there is no repetition at all, then we call that patternless. If it has a pattern, then there must be some kind of repetition of whatever it is, lines, shapes, colors, and it is on a surface. Okay, so it has to be on a surface. That is what the meaning of a pattern is. And you can have gross or microscopic patterns. Now, gross patterns, you had a lot of that being described the other day, cobblestone pattern, other, patterns, honeycombed patterns. Okay, let me ask while I'm about it. You've all heard of caseous necrosis? Yes, Jyoti, you've heard of caseous necrosis? Is Jyoti there? Or she's Jyoti, you are muted. I think maybe everybody was muted by Ruchi. Oh, no, you're okay, Jyoti.
Yes, ma'am, I've heard of caseous.
Okay, so what is this caseous? And I'll tell you why I'm asking you that. What is caseous?
Ma'am, it's a tissue cell death that causes cheese-like appearance.
Yeah, but where is that cheese-like appearance, Jyoti?
It's
Is it gross or microscopic?
It's grossly.
It's gross. All right, let me ask Shubhra. A cheese-like appearance, is it gross or microscopic? Say whatever you like, Shubhra. No? All right, let's ask Sudesh. Sudesh, caseous, is it gross or microscopic? Are you there, Sudesh? Can you unmute yourself? Yes, very good, Sudesh. Tell me.
It's microscopic.
So Sudesh thinks it's microscopic. Jyoti thinks it is actually gross. All right, can I ask Neha? Neha, what do you think? It is gross or microscopic? What do you think? It's a pattern. Yes, it is.
Ma'am, it's on gross also if you're saying cheese appearance, then it can be found.
And you see microscopic cheese, do you?
No,
you see microscopic cheese?
We have
Now, let me tell you that all of what you have learned as necrosis, right? What are the three different kinds of necrosis that you have, common kinds of necrosis, Neha?
Ma'am, caseous necrosis, coagulative necrosis.
Yes, and?
That?
Yes, so there's liquefactive necrosis. Excellent, excellent. A lot of students tell me that this is all, that you can see this on histology. Actually, you can't. Okay, all these are patterns that you see on gross. So coagulative necrosis, liquefactive necrosis, and caseous necrosis are all gross descriptions. You may not want to call them patterns, you may want to call them descriptions, but they are gross descriptions. All right, because we know what they look like on gross, and we know what that corresponds to in microscopy. You think you know what is caseous, but caseous is just any necrosis. No, how would you, unless you know that it looks cheesy on gross, you will not be able to tell that this is caseous necrosis when you are looking at it under the microscope. Also liquefactive. How do you know that something is liquefied unless you have seen this on gross? Okay, so these are gross patterns of. So you heard a lot about that at the last lecture. Okay, now what does histopathology do? Microscopy do? It describes a two-dimensional surface, because the description of a pattern is something that you see in 2 dimensions on a surface. And that's what we call a pattern of a 3-dimensional object, which is called a structure. So we have to, just like the radiologists do, we have to look at a 2-dimensional pattern and we have to create in our heads a 3-dimensional structure, an object. And that, to me, is one of the first lessons that we have to learn when we are trying to practice histopathology, to convert what is 3 dimensions as 2 dimensions on a flat surface, because all our slides are flat, into a 3-dimensional object. And please remember this and try and do it every time you're doing it. Okay. Now, as I told you before, the characteristics of individual cells do not themselves define the pattern, because we're not describing cells in a pattern. We're describing the way the cells and the stroma are arranged to make some kind of repetitive or patternless way of being represented on that surface, which is the slide. Okay. Just to give you an example over here. Clear cell tumor describes the cells of a tumor, not the pattern in which the cells are arranged. Okay, so clear cell tumors may be in a glandular pattern, clear cell tumors may be in a diffuse pattern. It can be in any kind of pattern, but the cells may be clear. So clear cell does not describe a pattern. On the other hand, if you say that this is a papillary clear cell tumor, that describes the cells and the pattern in which those cells are growing, okay, which in this case is papillary. So I hope you're getting the picture. Now, on the other hand, you get spindle cells, and these spindle cells can be arranged in several patterns, each of which has got diagnostic value. Now, why did I pick up spindle cells? Because there are some patterns that cannot be reproduced by cells other than spindle cells. Okay, so we'll come to that in a little while, because when you see spindle cells, you can get several patterns that spindle cells can assume, but which other kinds of cells, like for instance, I cannot get a fascicle of clear cells. Okay, and we'll talk about that later. I can get sheets of clear cells. I can get sheets of spindle cells, but I can't get a herringbone pattern of clear cells. So the cells are important, but they're important because some kinds of cells cannot be seen in some kinds of patterns, and that's why we need to understand this when we are making our, once again, Pradeep, please do not ask for annotation, whoever Pradeep is. Okay, now here is a floral pattern. You know what is a floral pattern? That means you look at all of these three and you know that they are flowers. Okay, but what are the individual stitches over here? This is embroidery that has made these floral patterns. Okay, this one is a cross stitch, this one is a lazy daisy stitch, this one is a satin stitch. If you consider that these stitches are cells, you will know immediately that it is not the cells that we describe in a pattern. It is the way in which those cells are put together that determines what that pattern is. If there is any question about this amongst the students who are interacting with me or anywhere else in the chat box, please let me know. You must know that cells constitute patterns, but cells do not by themselves mean that they form the pattern. So we're not talking only about cells, we're talking about the pattern in which they are. Okay. Now patterns, as we all know, are best appreciated at low power. This is like Google Maps. You know that the further away you are, the more perspective that you get. You see now if anybody has been watching the Israeli-Palestine conflict that is going on in Gaza, you will see, you see the Google Maps, you see what is the layout of all the buildings, and suddenly there is a bomb or some kind of missile, and a whole big area is flattened. And you can compare the two Google Maps that are taken from a height, and you'll see this. However, if you go, street by street, you can get the Google Maps down to the street. You may not know where that particular sort of bomb was, what was the area that was bombed, because you did not have the perspective. So if you're looking for patterns, you should try to look at this at low power, where you see a cone and you are able to see a large area in that cone, right? And these are 5. What do I use low power for? What should you use low power for, apart from just looking at the pattern or patterns of the abnormal? And these are 5 things, and please put it into your diagnostic armamentarium. Use it. If you find that these things are helpful for you, then please use it. The first question I always ask myself at low power is there any normal tissue? Again, that is recognizing if there is normal tissue there, which means that you're recognizing the cells and the pattern that makes normal tissue. Then you ask yourself, is there any abnormal tissue? Again, you have to recognize that the pattern of normality is no longer there, and you are seeing something that is abnormal. Once again, the third thing is, what is the relationship to the abnormal to the normal? If you're looking at something like skin, where is this abnormality? Is it in the epidermis? Is it in the dermis? Is it at the junction of the epidermis and dermis? Once again, it is about recognizing some pattern to where that abnormality is. Of course, the pattern of the abnormality is what we ask at in question number 4. 5 is, where do you want to go and begin your high power examination. Okay, so now we'll come to patterns in histopathology, and I'll show you as many as I possibly can. It cannot be an exhaustive lecture, so I'm not going to, I probably have missed out many patterns. Anybody wants to ask me about any pattern, you can always put it in the chat box. So we start with cellular patterns of growth and organization. So how the cells are growing and how they are organized. That forms one pattern of the cell compartment. Then you have the stromal compartment, and that too has patterns of how the stroma is arranged with respect to the cells. So interaction between the cell and the stroma. So there is a pattern to stromal reactions and what kind of extracellular matrices are present. Then you have patterns of cell death. You know that. And the patterns of cell death that we described a little while ago were the gross patterns of cell death. But we have patterns of cell death in tissues. We call it apoptosis, we call it necrosis, and there are different patterns of necrosis that we will just touch upon, because I'm not going too much into the patterns of necrosis. I'll talk more about the patterns of cell growth as well as of stroma. Now, these patterns can be repetitive, and we need a certain amount of repetition, as I said right in the definition of what is a pattern. Otherwise, it is not a pattern. Now, that repetitive pattern can be patchy, in which case you get variegated patterns, different patterns in different places. Okay. Or, as I said, you can get something that is patternless, because there is no repetition at all. You just see the same thing right throughout. It's like a sheet. So whenever you want to use the word sheet, please remember that you are using a term which means patternless. There is no pattern to this sheet. Okay, that's the first thing. Now I'll just finish off with patterns of necrosis. Will somebody tell me? I think Shweta has answered. Let me ask Pratibha. Pratibha, oh dear, some Rainy is now asking for annotation. Please, okay. Pratibha, are you there, Pratibha?
Yes, ma'am.
Very good. Pratibha, now you see the first picture on the left-hand side.
Yes, ma'am.
Okay, what is that pattern of necrosis? And if anybody wants to answer in the chat box, please go ahead, because we've got Nisha and we've got Shrutika who will tell me. But first, let me ask Pratibha. Pratibha, what is that pattern of necrosis? Pratibha, you have done 4 months in histopathology, right?
Yes, ma'am.
Good. So, do you see a pattern there in this necrosis? You know, no? What is this necrosis? Let me just change my pointer. Then maybe you can see this. You see this?
Yes,
It's
ma'am.
a pattern, right?
And the students in
This
chat
is the
box
necrotic area. Very good. Come on, Pratibha. Any ideas of what this pattern is, or have you ever seen a pattern like this? Have you ever described it?
The map-like area.
Map-like, that I think is very good. So now tell me, Pratibha, what do we call these map-like areas of necrosis? Then we have to give it a name. Okay. So what is that name called? What kind of necrosis do we call it? Pattern of necrosis do we call it? Any idea what name you would use? Yeah, you said map-like. Where do you find the maps?
Geographical area.
Geographic. So first class, Pratibha. It is a geographic area of necrosis. Okay. Very good. So who's next? There's Anjana. Anjana, are you there?
Yes, ma'am.
Okay, Anjana, look at the next picture. What do you call that? What is it? Anjana, you can see this, no? The middle picture? Very good. Have you seen this before, Anjana? You've done 3 months. I'll give you a clue. This is a breast. Okay? And it's a tumor in the breast. Does it make, have you seen it before? Have you made any sense of this? No? All right, let's then go to Sudesh. Sudesh, what pattern of necrosis is this?
The map-like area.
What pattern of necrosis is this? What is that pattern of necrosis? 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 What is that pattern
It's comedonecrosis.
Comedonecrosis. Excellent. Now, would you like to describe to Anjana why you called it comedonecrosis? Why is it comedonecrosis? You recognized it, didn't you, Sudesh?
Yes, ma'am.
So if you recognized it, then you should be able to articulate. Why did you call it comedonecrosis?
Because it looks like a small bump, like, ma'am.
A bump? Does it look like a bump to you?
With necrosis surrounded by
Like a surrounding.
Yes. Somebody was saying that. Who was saying it? Shubhra? Was it you, Shubhra, or somebody else? Or was it Anjana?
Anjana. Me, ma'am.
Tell me, Anjana. Yes. What is it?
With necrosis surrounded by the perfusion of
Normal.
By normal? I don't think it's normal.
No.
No? Just only this test. In this case, it is a carcinoma. Okay. Yes. So what actually does comedonecrosis mean? Okay. Yes, Anjana. What does it mean? You've heard of a comedone? What's a comedone? What's a comedone?
Blackheads, ma'am. Blackheads, whiteheads.
Black and white?
Blackheads, whiteheads.
Ah, blackheads. Yes. Okay. Whiteheads or blackheads. Yes. And those whiteheads and blackheads are actually necrotic tissue, right? Yes. And surrounded by
Area of
space.
necrosis.
Yeah.
Dead
So they
cells.
are within a space, and there is something that is surrounding that space, and that
Yeah,
something
plastic
that is surrounding the space is usually epithelial. Yes. So you've got this space over here, which is in this case epithelial. It's a carcinoma. Yes, Sudesh. It's a carcinoma in which the
Epithelial
central
cells.
area has become necrotic. But all comedonecrosis is not seen only in carcinomas. Okay. You have duct ectasias in the breast in which they're perfectly benign. The central area is thick and necrotic material, and around it. Or thick. I won't always say that it is, in this case, it is a necrosis. Shaili, please do not ask for an annotation. Okay, so this is comedonecrosis because there is this debris that is sitting in the middle of this tumor. So you can get necrosis, you can get viscid comedo material inside any kind of space that is lined or surrounded by an epithelium. Very good. So now who's after Sudesh? Neha, what do you see on the right hand side?
ma'am, acellular structure, mainly cognitive.
Acellular structures. What do you mean by acellular structures?
Ma'am, looks
What
like
is a cell to you, Neha?
ma'am, with the nucleus and borders. It can
So
be
a cell to you is something that has a nucleus and what?
borders.
Borders.
A line. around it.
Lining. A cell has got a nucleus and a lining. Come on, Neha, we're doing pathology now. This is not biology 101. So what is a cell? How do you define a cell? What is a cell, Neha?
Ma'am, anything with the smallest basic unit of life.
Oh my goodness, no, I'm sorry. That's not how I will be able to recognize a cell under a microscope. If you tell me that the cell is a basic unit of life, Neha, you'll be able to recognize that under the microscope.
No, ma'am.
Yeah? If I was shown a virus, you would call it a cell? Huh? Is a virus a cell, Neha?
Huh?
Is a virus a cell?
Ma'am, with the nucleus, we call it a cell, with the borders of the cell.
Nice. And what is this borders you are going on about, Neha?
Ma'am, with the nucleus and cytoplasm around it.
Oh, then so now we have come to cytoplasm, right? So what defines a cell, Neha? The nucleus or the cytoplasm? The cytoplasm.
Both.
Both. Right. Who's next after Neha? Jyoti?
Yes, ma'am.
Yes, will you please tell Neha what is a cell?
Ma'am, cell has a protoplasm. It contains both cytoplasm and nucleus.
I see. Jyoti, suppose I tell you, even in the human body, you have a red blood cell, right? You call it a cell?
Yes, ma'am.
Yeah, does it have a nucleus?
No.
But is it a cell?
Yes, ma'am.
Excellent. You have bacteria? Are they cells? Is a bacterium a cell? Jyoti?
Yes, ma'am.
Oh, it is. Does it have a nucleus?
Mhm.
Yes or no?
No, ma'am.
No, ma'am. So you don't have to have a nucleus to be a cell, right?
Yes, ma'am.
So you've got prokaryotic cells and eukaryotic cells. And there are many other different things, but at least from your point of view, you have to know prokaryotes and eukaryotes. So what is the difference between a prokaryote and a eukaryote? Let's clear this now once and for all, because people go around not knowing how to know what is a cell. Yeah, so tell me, what is a prokaryote and what is a eukaryote? You've heard about it now, Jyoti?
Yes, ma'am.
Yes, tell me.
Ma'am, a eukaryote has a cell membrane and a nucleus and organelles, but in a prokaryote, there is not a definite, there is not a membrane or
There's not a membrane.
The nucleus is not bound by the membrane.
So there is DNA material, but it's not bound by a membrane, right?
Yes,
But it has a cytoplasm.
Yes.
Okay, so what is the cytoplasm issue that makes a cell? Why is an RBC a cell? Although it has, it's devoid of a nucleus. So what is that? Neha, have you got the point? What? You agree that an RBC is a cell? Yes, Neha? RBC is a cell? Or are we just calling it a cell, naam ke vaste, and saying red blood cell? What? Oh, Neha's not sure that an RBC is a cell. Shweta, is an RBC a cell? Is Shweta there? Shweta, are you there or you disappeared?
Shweta is not there, ma'am.
Oh, she's gone. Achha, very good. What about Shubhra?
Yes, ma'am. RBC is a cell.
It is a cell. So what makes it a cell? It doesn't have a nucleus. And we are all eukaryotes. No? All our cells are eukaryotic. The word karyo means cell. Okay. So anything that has a karyo means has a nucleus, not cell. It means a nucleus. So we have cells, and prokaryotes have no nuclei. So we have nuclei, and therefore our cells are eukaryotic. So is the RBC a cell? And you said yes. So what makes it a cell? Has it become a prokaryote? No, it hasn't.
It has
lost its nucleus. So what is it that makes a bacterial cell a cell, an RBC a cell, all our cells? There is a membrane-bound protoplasm. No, there has to be something that is bounded by a membrane. Yes? Yeah, so that is what makes that a cell. So now tell me, who was looking at this? Neha, you were looking at this, right? This right-hand side thing. Yes or no?
Yes, ma'am.
All right, now tell me. You said acellular material. So are you still calling this acellular, Neha?
No, ma'am.
No, so what is it?
Ma'am, liquefactive necrosis.
Liquefactive. 1 minute ago, Neha, not 1 minute, maybe 5 minutes ago, we decided that liquefactive was a gross
Gross.
appearance. Do you think this is gross? I'm showing you gross? No. So what are you seeing? Can you identify this tissue? Neha? No? You can't identify the tissue. All right. Pratibha, can you identify this tissue? That you're seeing, Pratibha, are you there?
No.
Yes, ma'am. So come on, Pratibha. Can you identify the tissue? What do you see? You see all these little, can you see these little wiggly things? And what do they have in the middle of that? They have got a lumen. So these are tubules. Okay, so where will you get so many tubules like this? And here we have introduced a pattern, okay, composed of cells which have a lumen. All the cells are arranged such around the lumen, and they have a certain flexibility. Yeah, they're cylindrical, but they have a flexibility. So what is this? What is this tissue, Pratibha? It's the testis. Okay, that's the place where you get so many tubules. And normally seminiferous tubules, Neha, should be full of nuclei. What is missing from this is nuclei. So you can't talk about it as being acellular. Okay, so the nuclei have gone, but the outlines of the structure, you see the structure, the tubular structure, the cells that are forming those tubular structures are still there. There's a large area of hemorrhage to the right of this section. Okay, so this is necrotic. We're talking about necrosis. I can't now go into what is necrosis. Okay, this has lost its nuclei and therefore it is necrotic. So what is that type of necrosis in which you still see cellular outlines, you see cell organization, tissue organization, but the nucleus has gone? What do you call that, Neha?
Coagulative necrosis.
Coagulative necrosis. Okay, so coagulative necrosis, Neha, is not about looking at something grossly. All right, yeah, this testes would have looked different grossly, but you are able to see coagulative necrosis very well under the microscope. Okay, so this is coagulative necrosis. And this is due to hemorrhagic venous infarction. That's just by the way. Have you got the points now about patterns of necrosis? Geographic necrosis, comedonecrosis, and they all have a pattern and a definition to this necrosis. Now there are different. Is anybody asking any questions?
Yes, ma'am. There is a pertinent question: how to differentiate central necrosis in DCIS as comedo and non-comedo type?
Central necrosis in DCIS well, whenever you get central necrosis, which shows you when it is high grade, whatever is around it, and it looks very solid and viscid. Please look at this. Okay, this looks dried up, almost as if when we're talking about viscid, means that it has been sucked out of all its fluid content. That's what we call it. But if you call central necrosis in a duct carcinoma, comedonecrosis, nobody is going to make an issue, because diagnostically it hardly makes a difference. Okay, so I don't care whether or not somebody calls something comedonecrosis, as long as you know that it is necrotic. That's number one. It is surrounded by some epithelial structures, and it is debris that has come from the necrotic cells. It's fine. I don't think that there is a great deal of difference between this. And once you see necrosis, it's a bad sign. Okay, in whether in any DCIS. Okay, now we have to classify the major growth patterns of necrosis.
There's another question. Can we take
Yes,
that?
tell me.
How to differentiate tumor necrosis from other types of necrosis?
You've got to see the tumor, no? Otherwise, how will it say? If you don't see any tumor, can you distinguish any other necrosis from tumor necrosis? I don't think so. I'm not sure what the drift of the question is. Okay.
Okay, thank you, ma'am.
Yeah. So anyway, we have to classify major growth patterns, and here I just classified them. I just made up the classification. Okay. And you have solid growth, cystic growth, pseudocystic growth. You can have mixed patterns which are solid and cystic, and then you have these other circumscribed, encapsulated, fully encapsulated, partially encapsulated, infiltrative or invasive. It's the same word that you can use. There's nothing different between infiltration and invasion. And there are two kinds of infiltration, and that's very important for diagnosis. Okay, and that's a pattern of infiltration. One is destructive, and the other is permeative. And then you have another way in which it's mainly tumors that that can give rise to, because infiltrative, invasive, etc. Capsulated and encapsulated may happen in many things. It can happen with abscesses, it can happen with tumors, it can happen with cysts or whatever. But normally, when you can have an erosive or an expansile pattern of growth, it is usually a tumor. Okay, so yes, you can say that aneurysms erode, but that's not what you're going to see in histopathology. Okay, so when you're seeing an erosive or an expansile growth pattern, you will see it in histopathology. Then there are other patterns. You did hear about nodular, lobular. You have radiate patterns of growth. You get diffuse sheet-like, which is for all practical purposes a patternless growth pattern. You see polyp, polypoid, or ulcerative patterns. Okay, so now I want somebody to, you've heard all these terms. Here on the left is a soft tissue tumor. On the right, there is a lymph node. Okay, now I think Pratibha was last. Now Anjana, you see the soft tissue tumor on the left? Yes? All right, now just tell me, what patterns do you see there which you would like to use in your description? You're going to describe, this lesion. I'm not asking you to come to any diagnostic, sort of final diagnosis. I just want you to describe the patterns. Come on, Anjana, it's not very hard.
No, I feel it is a lobulated or nodular architecture.
Lobulated or nodular. Make up your mind whether it is lobulated or nodular, and the two are not the same. Make up your mind. Come on.
Lymph node is in nodular architecture.
I want you to talk about the soft tissue tumor, please, Anjana. You see the soft tissue tumor on the left-hand side?
Yes, ma'am.
That is the soft tissue tumor. Now, just tell me about the soft tissue tumor. What is it? Tell me about the patterns that you see.
Lobulated.
Okay, you're saying that it is lobulated. Do you see any other pattern? No? All right, so Anjana says lobulated. Sudesh?
Sir.
Left side. I'm talking about the left side. What do you see? She said lobulated. A, do you agree with her? B, do you see anything else? Sudesh, can you see?
Looks like a nodular pattern.
It looks nodular. All right, so we have two descriptions here. You have lobular, and you have nodular. All right, anything else you see, Sudesh? No? Okay. Let's ask.
Six spaces.
Sorry, you see some spaces. Achha, okay.
6 spaces in between.
Cystic spaces in between. Okay. Right, Neha. Back me out to Neha.
Yes, ma'am.
Now tell me, what pattern do you see? Do you agree with Sudesh or you agree with Anjana?
Ma'am, I see a pattern with in between
What are you seeing?
stroma.
Sorry, slowly. What are you seeing?
Ma'am, in between stroma is
In between stroma. But what is the pattern that you're seeing? Yeah,
nodular
Neha?
pattern.
Nodular pattern. Any other pattern? No. Okay, Jyoti.
Ma'am, it seems encapsulated.
It is encapsulated. Wonderful. And what other pattern do you see? Do you agree with Sudesh? Or you agree with Pratibha? Anjana, sorry. What? Come on. You heard them say no. One said lobular, the other said nodular. So, Jyoti, with who do you agree with? Jyoti?
Ma'am, mixed. It looks like
Mixed. Acha. So Jyoti, you should have been in the diplomatic corps.
Ma'am.
You should.
Lobular.
Huh?
Globular, ma'am.
Lobular. All right. So you agree with Shubhra?
Yes, ma'am. There are nodular patterns as well as there are small nests of cells infiltrating.
Acha. So you can't have small nodules, do you think?
Yeah, we can say them small nodules even.
Can you see a nest? Do you think you'd be able to see a nest at low power? What do you think? Shubhra, can you see a nest at low power? What can you see at low power? You should be able to see larger structures, no?
Yes.
So the larger structure or the larger pattern would not be a nest. Okay, and for a nest, I would have to go. This is extremely low power. This is almost a 2x. So you can't see. You can see nodules. You said nodules. And do you see anything else? Do you agree that there is a capsule over here?
Yes, ma'am.
So if I had to describe this is the whole purpose of this. This is not to go one after another. This is a nodule. This is a this. This is a that. You have to be able to put your knowledge of the language that we speak into a description. All right. So what is that description? It is a solid. Number one. Is it solid or is it not? This is not cystic, right? So it is solid. It is encapsulated and it is nodular. So if I am describing or you were describing this lesion, you would say that this is a tumor that is solid. It is encapsulated and it is nodular. Okay. Now that you've seen that, is there any difficulty in describing what's going on the right hand side? Is there any difficulty? No. Who's going to take that? Anjana or Pratibha, did you answer just now?
Yes, ma'am, it's solid and nodular.
Exactly. So it's nodular and it is solid. So that is what it happens to be a lymph node. So this thing is solid and nodular. So you can say all lymph nodes are solid. They are hardly likely to be cystic. So nobody talks about solid when you're talking about a lymph node. But when you have a soft tissue lesion, you don't know what that lesion could be. You will have to describe it. And once again, I'm telling you, if I wanted somebody to describe, to be my eyes, and I was told that this was a soft tissue lesion, I would want to know whether it was solid or cystic. All right. If it was a lymph node, I know that it is solid. A lymph node is not likely to be cystic. So if somebody tells me there is a cyst in a lymph node, then it's a diagnostic entity. But if you say that the lymph node is showing a nodular appearance, you can add solid if you want, but it is an unnecessary descriptive term. Do you get my point? But it is not unnecessary when you're describing something that is usually you don't know whether it's going to be cystic or it's going to be solid. Fine. So this is these are what nodules are. Now, how do you define a nodule? Why did you call this a nodule? Several of you said nodule or lobule or something else. So why is it nodular? You said it was. So why?
Because it is rounded and well circumscribed space.
Very good. It is well circumscribed, and you use the term rounded. In other words, all of this is not rounded. No, there are parts of it that are cone-like. Some of it is irregular. But there is one pattern or external pattern of growth that is seen both on the left-hand side and on the right-hand side, and it is this. All nodules are large. Okay, so on histopathology, you don't have to go to a very high power to see a nodule. See nodules when you are at 4x. Nodules you are seeing at 10x. You might have to go to 25x or 40x to see smaller structures like nests, etc. But you are seeing these at at low power, 2x and 4x. So they have to be large. And they have an arc at some edge or the other. That was what Sudesh said is rounded. Okay. So there is an arc-like shape to a nodule. That's something that is very much part of the definition of a nodule. Now, do you remember how the word nodule actually came? Because I thought Dr. Dasgupta's lecture was so nice because he actually gave you the etymology or the derivation for each of these terms. Anybody remembers what the nodule word is actually derived from? It's a word for knot. No? So nodule, because nodule is just a small version. That's why we call something lymph node, and it's because it looks like a little knot. You know that in many colloquial languages, the word for a little growth as well as a knot is the same. They call it the gart. You know that? I don't know why. Do any of you recognize the word gart?
Yes, ma'am.
So that's exactly the same word. It's knot, and that's why we say lymph nodes. When the lymph node enlarges, they say gart, which means that we have got a little knot that has come up in the body. All right. Now let's go to Neha. What are you going to classify this? You've got two. A low power and a high power on the right that belongs to one lesion, and a low power and a high power on the right that belongs to another lesion. Can you tell me what the left-hand side lesion is? What are you going to describe it as? Come on, Neha. Where are you? Are you there? Has Neha left? Neha seems to have left. Okay, Jyoti. Tell me, do you see any pattern that is present in this? This is all of one low power, high power of the same lesion. Is there anything here that tells you about a pattern? No? Nothing. Not even in the high power.
Circumscribed or cystic, like this, like.
So they make up your mind. Circumscribed means what? What you're seeing is a cystic lesion, right? This is cystic. You see multiple cysts over here. So this is a cystic pattern. And you would say that these cysts, if you had to describe it, are under some squamous epithelium, right? So it's in the subepithelium. That's not a pattern. But this cystic structure, and this happens to be a mucosa. So there is the submucosa is showing a cystic pattern. There is something that is a whole lot of bunched up cysts. Neha, do you think it's the same on the right-hand side? Do you think it's cystic? Or not cystic? What do you think? Is it cystic or not cystic? You're having difficulty in telling whether it's cystic or not? Maybe Shweta's left, right? So Shubhra, is this cystic or not cystic? On the right hand side?
Cystic.
Of course it is cystic. So you have these are cystic growth patterns. On the right hand side, you can see that the cysts are lined by an epithelium. Very clearly, you can see that the cysts are lined by an epithelium. What is the cyst on the left hand side lined by, Shubhra? Is that an epithelium?
Cells, yeah.
It's an epithelium. Do you think? Can you describe what it is lined by?
Strands of cells.
Strands. What do you mean by strands?
Like alveolar pattern.
Alveolar pattern. Well, it's a cyst, and you can see that the cyst is lined by a flattened lining. Can you see or not? It's flattened. These are words that you have to learn to use. This is the language of pathology that we have to learn to speak. Okay, so it's a flattened lining. All right. So, and it's got inside, you can see that there is some very pale eosinophilic material. So if you say that it is a cyst, these are cysts that are close to one another. They all have a flattened epithelium. It's not an epithelium in this case. It is a flattened lining. Then you know what these cysts could possibly be. So you have your cystic structures in a subepithelial position, which tells you exactly what this is. And then you say there is a flattened lining to it. And you say that in the center, there is this very pale eosinophilic material, and then you know what it is. On the other hand, what do you have? A cystic epithelial structure. So this is subepithelial and this is epithelial. Now, if you want to arrive at the diagnosis, there shouldn't be any problem at all. What do you think this diagnosis is on the left side? Sudesh, you've done 8 months. Come on. What do you think? Do you think it's epithelial? And the answer, you can see it on the hyper. And the answer is no, it cannot be. Okay, that is a lymphatic. So this is a lymphangioma. On the right-hand side, it is a cyst. It happens to be in the pancreas. That's neither here nor there. We're only talking about patterns. So that is a multicystic tumor, which is in the pancreas. All right, that's what is known as a serous adenoma, serous cystadenoma of the pancreas. But how do you define a true cyst? Both are true cysts. Okay, because they have an inner lining of cells forming a definitive layer or layer. Here the lining is endothelium, and on that side the lining is epithelium. You can get mesothelial cysts, and they are true cysts. Okay, do you have mesothelial cysts in the abdomen? You can get mesothelial line cysts in the pleura. They are true cysts. So somebody tells you that true cysts are only lined by epithelium is not entirely true. Okay, you can get true cysts of endothelium. You can get true cysts of mesothelium. We have to know then if these are true cysts. Okay, what are pseudocysts? Now, what do you see over here? You see that there is a solid. You see the solid pattern? Yes or no? Yeah. And that solid pattern is punctuated. Yeah, see, this is how we make a description. This solid pattern is punctuated by cysts that are interconnected. There are cystic spaces. You see that? Big spaces that are interconnected with one another. Now tell me, could this be a true cyst? Or do you think that these are, you can see them all, both, this is the same tumor on both sides. So you have got an encapsulated, solid tumor with cystic spaces. And the question is, are these true or are they pseudo? Now, let me take a poll from you guys. All right, in the sense you can ask it in the, anybody wants to write in the chat box, it's fine. But let us ask Pratibha, true cysts or pseudo cysts? I might, sort of have given you a true cysts and you will call them pseudo cysts. I'm not really trying to, to have fun at your expense, but you can see that they cannot be true cysts, because they're all interconnected. And how have they formed? That's the important thing. How have they formed? They have formed actually by edema in the stroma. Can you see this? This is all edema in the stroma. And this edema in the stroma is pushing the solid areas apart. So this is not true cysts. This is stromal, this is edema or stromal something has collected in the stroma and is pushing the solid things apart. So this is not a true cyst. This pattern over here is pseudocystic encapsulated. Okay, so these are the patterns that you see. So the moment somebody says pseudocystic, and if somebody tells you that this is in the pancreas and it is pseudocystic and it is encapsulated, and I know enough about pancreatic, I would say, I know what this tumor is, and then I can even ask you questions about how the cells look like, because I know that SPEN is a solid pseudocystic epithelial neoplasm of the pancreas. See how beautifully this has been described. It is solid, it is pseudocystic, it is encapsulated. The diagnosis is there in the description. So you see, folks, how if you make the right observations, you are going to arrive at the right diagnosis, because, as I will tell you in a little while down the line, the reasons for knowing how to use words is because they trigger thoughts. Okay, if I put it together, solid, pseudocystic, encapsulated, and I know that it is in the pancreas, there it is. It is a SPEN. You may not know this entity, I don't care, but you should be able to recognize the patterns that you see. All right, come on, somebody now. Anjana is finished. Sudesh, classify the one on the left, then we'll go to the next, and then we'll go to the next.
Looks like cribriform pattern.
Cribriform pattern.
So there is a sieve-like spaces.
Sieve-like, acha. All right. What do you think this is? Also cribriform?
No.
No. And this? No. So what do you think is common over here between this, and this? Why did I put up these three pictures together, Sudesh? Why do you think I put these three pictures together? And if I wanted to show cribriform pattern, why did I have it so small in that? This is all low power, extremely low power. So come on, Sudesh. No? All right, Neha. Neha, are you there? Neha's gone. Jyoti, you're there? Jyoti seems to have gone. All right, Pratibha.
Yes, ma'am.
Tell me.
Jyoti's here. We can't hear her.
Oh, we can't hear her. Okay, then she needs to. Come on, Pratibha. Why have I put these three things together? What do you think the patterns that I'm trying to get at over here? Do you think that this is about patterns of infiltration? All right. Yes. So what is this pattern of infiltration? So this is number one, infiltrative. About number two is infiltrative. What do you think about three, Pratibha? Is it infiltrative? No. Okay. So Sudesh, you like to tell me what is this pattern of infiltration in these two, number one and number two? No. All right. Let's have Shubhra. Shubhra.
Yes, ma'am.
What is this pattern of infiltration? First of all, do you think it's infiltrative?
Yes, more infiltrative.
The answer is yes. Yes, this is infiltrative. Do you think this one is infiltrative?
Yes.
Yes. Do you think this is infiltrative?
Yes, ma'am.
The third one is infiltrative? The answer is no. Okay. What do we have? This one is infiltrative destructive. It is destructive infiltration. Anything in the path of that lesion, in this case it is a tumor, has been destroyed. Okay. So you can get this pattern of infiltrative destruction in many things. You can get it in inflammation which is simply destroying tumors. You know, that's how you get an abscess, right? An abscess at the periphery, it's going to simply destroy. Have you seen a lung abscess ever? Or have you seen an abscess anywhere? It is an infiltrative thing because inflammation is infiltration and it has destroyed everything in its path. So that is infiltrative destructive. Usually we think of it with tumors, but look at it here. This is an infiltration. This happens to be a lymphoma and this is infiltrative permeative infiltration. And there's a big difference between the two. When you see this kind of permeation, what is the meaning of permeation? Yeah, Shubhra? What?
It's like the tissue. It's same everywhere. The pattern of infiltration is same everywhere.
Everywhere, Shubhra. No. What did we, when in English?
Regular.
Huh, sorry?
It's regular.
No, absolutely not. Come on, Sudesh or Anjana. Anjana, I haven't asked Anjana for some time. Anjana, what is the meaning of permeative? It's sitting there in front of you.
Spreading.
Letting something go through it, but it's
Yeah. So permeation means it goes through without destroying what it is going through. So you know, water permeates through a sieve. You know, chine is a sieve which you use either for tea or when you're washing vegetables or anything. Yes or no? So the water goes through it. Does it destroy the sieve? Huh? What do you think, Shubhra? It destroys the sieve?
No, ma'am.
No, it doesn't. Now, this is what is happening. You see these things going, leaving the, the fat, in this case, fat cells intact. It could be fat cells, it could be muscle cells, skeletal muscle cells, it could be anything. But there is a permeative way of infiltration, leaving normal structures intact, which is not there in this kind of infiltration, which you see on the left-hand side. Okay? And there is no infiltration on this side. Absolutely none. What is this? These are do you think that there are little tumors or little cells that are actually going into the underlying tissue? No. What do you see? Big, bulbous ingrowths. Can you see that? That is not infiltrating. So, but yet this is a tumor. So it's doing something to the stroma. So what is it doing?
Pushing.
It's pushing, exactly. And that is what is known as erosive or expansive. Pushing, erosive, expansive. Have you got it now? Please, everybody. Is there anything in the chat box, Shrutika? No. Okay.
No, ma'am. No, nothing.
All right. So infiltrative. So you have now. You know what infiltrative and expansive is about? Do you remember what we have to look at low power? The relationship of the normal to the abnormal. So here you have normal fat cells, and the relationship of this is a permeative, infiltrative pattern of growth. Here you have fat again. And this is a destructive, infiltrative pattern of growth. Yeah, you don't see any fat here in the middle. You don't see any normal breast ducts. It's all been destroyed. Now here, on the other hand, it is an erosive, expansive way of the relationship between the normal, which is the subepithelium, and this tumor, which is growing from the epithelium. Is there any problem about this? Because I'm a little bit disappointed that these are patterns that you should be able to recognize like that, because this is what we use in everyday descriptions. So please, this is important. Learn these, learn how to use this, because the moment you say that there is permeative infiltration, what can do permeative infiltration? Things like lymphomas, lobular carcinoma of the breast, and you know that, you've seen that. It leaves the, the ducts intact and it is running around those ducts. It is not causing much destruction of what is going on over there. And inflammation. There are so many inflammatory conditions. Paniculitis, for instance. Yeah, we talk about septal paniculitis and so on. And there you have this infiltration that is going into the fat. So it doesn't tell you that it's a tumor. Infiltration does not tell you that something is a tumor. That's the first thing. Okay. And as I told you, most often erosive and expansive lesions mean that there is some kind of tumor that is expanding and is eroding whatever. So if you've got an encapsulated, you've got an adenoma in the thyroid, it is expanding, it's getting a capsule, that is expansile growth. I hope all of you are understanding what I'm saying. All right.
There is
Now,
one question.
Yes, please.
That erosive expansive, is it papillary?
No, it is not. No, it's not. How can it be papillary? Yes, whoever has asked that question doesn't understand what is papillary. Papillary has to have cores of tissue around which an epithelium is arranged. No, it is not papillary. Okay, anything that is growing in a way which may or may not be well circumscribed, but is pushing into the tissues in which it is growing. This is the meaning, and you can see this at low power because you can see this pattern of growth, and that's why I told you that these are the major patterns of growth. So I'm showing you the major patterns. There are some patterns which we will also describe. Okay, here. Anybody tell me what is this pattern of growth? Anybody recognizes it? Neha's gone, I think. Jyoti, she got back her. Has Jyoti got her? Jyoti, are you able to speak? No. All right. So we'll go back to Shubhra now. Yes. What is this pattern, Shubhra? All three are the same pattern. I'm just telling you this. So.
It's having both solid and cystic patterns.
Solid and cystic patterns. All right. That's what you say, Shubhra. Pratibha. There's Jyoti. She's come back. Can you hear us, Jyoti?
Yes, ma'am, I can hear you.
All right. So now tell me, what is all three have the same pattern? What is this pattern? Pratibha says solid and cystic.
Ma'am, it's infiltrating only, and
It's infiltrative. Acha, okay. Anybody else? Anjana?
I think it's infiltrating.
Infiltrative, okay. Neha is there or she's gone? I think Neha's gone. Sudesh?
It looks like infiltrative.
All right. It looks infiltrative. You know, this is a pattern that you have to recognize. Yes, it looks infiltrative, okay. But if you looked at the previous infiltrative, yeah, do you see how irregular this infiltration is at the periphery? Yeah. Look at this. Is this very irregular? Actually, it has pretty circumscribed nodules, right? But there is something that is connecting up all this together. And what is that? There is something in the center which is scarified. Okay, see this? It's scarified, it's scarified, it's scarified, and there is this nodular pattern at the periphery. This is a pattern that you have to recognize because you think that this is infiltrative, and then you see what looks like cribriform and a lot of proliferation within epithelial proliferation, and the next thing you're going to call this is a carcinoma. It is not. This is radiate. Now, what is the meaning of radiate? It means that you can draw lines that go from the center to the periphery. You see that? And they're all radiating towards or radiating away from the center. Yeah, and you have this pattern of nodularity that is fairly well circumscribed. You see, I'm making little nodular arcs around this lesion. It's a pattern that you have to learn, and you can only make this diagnosis at low power. If you go to high power and you look at all these epithelial proliferations, God forbid you are going to call it a carcinoma because low power said, it is infiltrative. Right? This is pseudo infiltration. And this is what you need to be able to recognize. Slowly you will. This is radiate pattern. And this is a classic example of a radial scar. Okay, that you see. It's called a radial scar because there is a scar in the center. Okay, you can have a lot of proliferation at the periphery. This matches so well the mammography. And in mammograms now, the really good mammographists can actually tell you that what they're going to biopsy is actually a radial scar. So just put this in your head. All right, here's another pattern. And it is a major pattern. Okay, Sudesh, you want to tell me what this pattern is? And it was referred to by Dr. Siddharth yesterday. But there were so many terminologies, so I'm showing you now just the terminologies that apply to patterns. What is this? Anybody?
Lobular.
Lobular. Excellent. Who was that, Jyoti?
Yes, ma'am.
Yes, it is lobular. Now, it might look at first glance that it looks like nodules, okay? And some people would say, oh, I think it's nodules. You see these nodules? But there's a reason why we call this lobular. Number one, look into each of these nodules, if they are nodules. You see that there is a big blood vessel here in the center, and then it breaks out into these tiny, tiny, tiny little blood vessels. You see it here, you see it there, you see it here, and then you also see something that there is a big fat blood vessel here, and all of these other nodules, so-called, are going towards that one big blood vessel. So if I had to actually show this to you, this is a diagram that I've taken from a textbook. You see this? Little nodules of the same thing, they're blood vessels, okay? All radiating towards or away from one point over here. Yes? So if we look at this, you see this? That's where it is all coming to, and each individual nodule has got a center from which you see lobules. Now, what organ is lobulated? Can anybody tell me? Neha, Jyoti, you answered that question. Can you think of which organ, if you didn't know, would look like this? And if you didn't know that these are blood vessels, what does it resemble?
Breast.
Yes, breast. Salivary gland, no? And salivary gland and breasts have got lobules. Why do we call them lobules? Because there's a duct which radiates towards the center from the big nodular lesions at the periphery. The duct comes towards the center, then many ducts coalesce, and then it becomes so it's a branching structure. And this branching structure is seen over here, just like you would see in a breast, or you would see, I could have drawn some other, cone-like triangles. And this is how it is. Okay, so we call this a lobular hemangioma. But salivary gland is a lobular arrangement. So also is the breast. It has lobules, which all, you have the intralobular duct that comes to the interlobular duct, then the interlobular duct joins up to form larger ducts, and finally it all comes up to the nipple duct. So there's a branching structure which you see over here, which is different from the radiate structure that we saw before. Okay, now this word lobular, and you told me about the breast. Okay, so it exhibits a lobe-like morphology. And what is this lobe-like morphology? Now, why do we say that the lung has lobes? Why do we say that the liver has lobes? Okay, why do we say that the salivary gland has got? Lobule is just a small lobe. So what? It's because it all comes and there is a hilum right at the center. That is what makes the liver and the lung lobate organs. In other words, that they have lobes. Lobule is a small lobe, and this is a lobular structure. But please, you have lobular carcinoma in situ affecting the lobule. That is a different kind of lobular. That is not a pattern. That is a diagnosis because the cells of those lobules are involved in this malignancy. Okay, so the lobular carcinoma does not have a lobular pattern of growth. Have you understood? So this is the way that we sometimes use adjectives, because lobular is an adjective and it can be confusing to students. So that is not what is lobular in the way that we use it for lobular hemangioma, lobules in the salivary gland, and other places in which you can get lobular patterns of growth. All right, here's another major pattern. What would you call the one on the left? Yeah, Anjana, what would you call this on the left? And these are lower patterns, and I'm showing you low power because that's where you see patterns. I don't want to know the diagnosis. Yes, Anjana, what is this pattern? What would you describe it as? Are you there, Anjana?
Yes, ma'am.
Oh, good. Then say yes, otherwise I don't know if you're there.
Yes, ma'am.
What is this? What is this pattern? No?
Polypoidal.
Polypoidal. Excellent. Of course it is. It's polypoidal. It is polypoid. Now you can see it. It's out into a space because look at this again. There is a surface over here. Okay, and it's not a ragged surface, so we haven't made that surface. It's a nice clean surface, and you've got air on one side. That means that or it could have been, it may be a cyst or whatever. So this is polypoid. Excellent. Now, what about the other one, Anjana, on the right? Low power. What is this pattern? I don't want you to look at the cells. I don't want you to look at anything. You're not making a diagnosis. You are making a descriptive. You're going to use a descriptive term. Yes. What do you think the tissue is? What do you think the tissue is, Anjana? Can you at least tell what the tissue is? Yeah. What is this? What is this? Do you think it's an epithelium, Anjana? It's an epithelium, right? Yes, it is an epithelium, and it is squamous epithelium. All right. So now tell me, what is this pattern, and why is the squamous epithelium only here and it's nowhere else? So what pattern is this? So yes, who said what? Yes, Shubhra. This is an ulcerative pattern. No, there is an ulcer. You can see this. So there is an epithelium which has been ulcerated. Here you have an epithelium in which there is something that has become polypoid. So when you have a surface, surfaces can show you something that's above the surface, which becomes polypoid, something that has excavated the surface, which is ulcerative. Okay, very good. So that is ulcerative. And now you guys should learn how to describe an ulcer. Okay, here is an ulcer. This is an ulcer which happens to be, doesn't matter what, but this happens to be in the stomach. Okay, and ulcers are described with having a floor, which is what you see when you look at it from the top, having a base, which is the junction of the ulcer with normal tissue. So that's called the base. Then you have edges. Okay, now you see this. This is an undermined edge. This is the real mucosa, and this ulcer has undermined the edge of this mucosa. Okay, so I tell you, you don't need to know what the diagnosis is. That's not important. You would describe this as an ulcer with, and you can see this ulcer is now above the surface of this. So there is something that is pouting above the surface, but this is the floor. This happens to be necrotic material, and it's all pouting above the surface of that ulcer, but it's ulcerated. Because what is an ulcer? Yeah, Sudesh, what's an ulcer?
Break in the continuity of the epithelium.
Anybody wants to disagree with Sudesh? Anybody is disagreeing with Sudesh, or everybody thinks that Sudesh is right? Is there anybody in the chat box who's disagreeing with Sudesh? I don't know how many times I've given this talk.
No, ma'am.
Nobody?
It should infiltrate up to vascular ulcer.
No,
Otherwise, it
that's
is not
not
as
an answer. So I'll tell you, Sudesh. Give me an answer to my question. You've been to a number of surgeries, yes, Sudesh? You've seen surgeries when you were in second, third MBBS, yes?
Yes, sir.
Yes. You've seen what the surgeon does, Sudesh? What does he do? He takes a knife, and what does he do? He incises the skin, right? Yes or no?
Yes, sir.
Yes. So then what happens? He creates a breach in continuity in the skin, yes or no?
Yes, sir.
So has he made an ulcer?
No.
Then why not? You just told me that the definition of an ulcer is breach in continuity of the skin, of an epithelium. Yes or no? So why hasn't the surgeon made an ulcer? You're smiling. All of you will be smiling. Because you never asked the question. That every single time a surgeon incises the skin with a scalpel, he is causing an ulcer, according to you, and yet you told me it's not an ulcer. Yeah, you fall on the ground and you scrape your knee. Yeah, is that an ulcer? Have you created an ulcer?
No.
No. So why? Why is it that the surgeon incising, you falling, causing a scrape is not an ulcer, and this is? Why? Anybody can tell me? Because there is nothing like an acute ulcer. Have you understood this? It takes time for ulcer to occur. So when a surgeon incises, this is an acute thing, right? So in the definition of an ulcer, there has to be the word chronicity. So it is a chronic breach and the chronic may be 2 days, it may be 3 days, it may be n number of days. Yeah, like your aphthous ulcer. Yeah, but it is not at one stroke. You didn't fall down and you've got an ulcer. The surgeon didn't incise the skin and there is an ulcer. Have you understood? So this definition of breach in continuity is not enough. It has to be that there is some chronicity, which means what? That tissues are being damaged over a period of time. Of course, when you fall down, the tissue is damaged. Of course, when the surgeon is incising the skin, the tissue is damaged. But over a period of time, this tissue damage occurs, and that is what an ulcer is. Okay? Have you understood that it's not just a breach in continuity? So this is the different ways in which we describe ulcers. We have to know about the ulcer edge, the ulcer floor, and the ulcer base. Edge and margin are two things that are often used synonymously. So you can have margins that are rolled, margins that are undermined, edges undermined, all of that. And you know that this is not just a gross thing. You see it even under the microscope. Okay, but much of our, like, an amoebic ulcer, it's a gross thing that you see the margins are undermined, but you can see that very, very well, even in a well-prepared histological specimen. Okay, now those were the